Hey, thank you, Keith. Appreciate that. Zoe, if you ever need someone to come back and talk about negotiations, as Keith mentioned, 15 years ago, moved from Scottsdale to Schwenksville and still married, but we're not talking negotiations today. We are talking key trends in the U.S. healthcare market. And I can appreciate, well, people like Ken that did spend time in life sciences at organizations like J&J and BMS. We've got other people from diversified industries, cement. So forgive me if I speak acronyms. I'll try and decode, spell those out, and give meaningful context to them. But at any point, please come off mute, raise your virtual hand, and or put some thoughts in the chat feature. And with that, we'll hop right to it. And so what we have done is every year, the second week in January, executives from large companies, be it Novartis or J&J or Pfizer, or AstraZeneca, all convene out in San Francisco for what is now known as the JP Morgan Healthcare Conference. We also follow heavily the CMS.gov, so the Centers for Medicare, Medicaid Services. And then, of course, the big lobbying group within the life sciences is called PhRMA, PHRMA. And so those are some of the sources that we go to curate our data to really decipher and put out to you the key trends that we look at. Typically, we work 90% of the time with either pharmaceutical companies or intermediaries, people that employers use to manage healthcare benefits, both medical as well as pharmacy. And so when we talk to pharma companies, and it's usually people in account management, people calling on hospital systems and integrated delivery networks or health plans like Blue Cross Blue Shield of pick your state, be it a IBC here in PA or Horizon in New Jersey, or sometimes these big pharmacy benefit management companies, aka PBMs. And so we always encourage them, whether it be with the Brooks Group on their own or someone else, to really keep a pulse on today's current and emerging market trends. And of course, that's not unique or germane to pharma. If you're in the cement industry or diversified, or you're in electrical engineering, of course, it would be critical that you keep a pulse on those current and emerging trends in your market. And what we like to say is, based off the market trends in your world, in your segment, to do a little bit of outside-in thinking. If you were to distill down all the disparate data and think about, hey, what are the 3 or 4 key trends and drivers? What are the implications to your customers, right? What does it mean to them? What are they doing about it, right? How are you seeing them evolve their strategies and go-to-market approach? Conversely, then, if we're equipped with that insight, we then ask our customers to say, okay, what's the impact to you in pharma? What are you going to do about it? And if their strategies are congruent with where the market's going, we then find they have a higher likelihood of achieving those strategies, thereby achieving their established business objectives. So Keith and Zoe, while I realize we are talking about healthcare trends, I'll try and be a little bit agnostic so it can have real world application to the broader group. I've got the trends in the U.S. healthcare market really broken into 4 sections. I'm actually going to finish up with section 2 on government and health policy, and we'll go sequentially 1, 3, 4, 2. What I talked to Zoe and Keith about, I'm going to walk through this, and then I'd like to pause and just get a couple thoughts from you in the chat feature about what you want to get out of this, because again, not everyone here is from pharma life sciences. But what I committed to Keith and Zoe was, number 1, I will identify and talk through those trends. As Keith mentioned, we do a lot of market research. We do a lot of ad panels. I was down in snowy Dallas this week, working with a medical director and someone that heads up their payer GPO over in Ireland. So again, it's not just through Keith and I's filter. It's through a good cross-section of different decision makers across the marketplace here today. We will talk about some of the different economics. We'll talk about how now nearly 18% of our GDP is spent on healthcare, what that's looked like over the last, let's call it 5, 6 decades, and some things driving economics today that really affect our fragmented healthcare market. Again, we'll finish up with looking at some health policies. And we've really got a lot of M&A over the last decade, a lot of vertical integration. And so we'll talk about what we call in the healthcare world, the big 3, looking at health plans and PBMs and specialty pharmacies and integrated delivery networks and provider groups, all these different segments, how they've really come together, so that they can deliver on their bottom line to Wall Street. And of course, as Zoe said, please do ask questions frequently throughout the process. So it's just not Ryan speaking through some slides. with that team, those are the objectives I've set forth. But if you would take a minute or 45 seconds, if you can go to the chat feature and just say, hey, Ryan, here's what I'd like to get out of this morning session. All right. Thank you, Jeff. Insight into new opportunity areas. And I believe Jeff, for everyone's background, if you don't know Jeff, big technology background, doing some pretty cool things around gamification to engage, in this case, patients or members to increase adherence to, I assume it's therapy, Jeff, but maybe not unique to therapy. Maybe it's to different care management modalities.
Mostly drug taking.
Drug, okay, yep. So drug therapy, right on. Ken's talking about the impact of politics in America. Ken, that's usually very fruitful at our networking event when we have alcohol on board, but we'll definitely speak to some of the health policies. I'll try and be apolitical. Thank you, John. Medicare redetermination and gaps in care. Yeah, we'll definitely get into Medicare, Medicaid, some of those different dynamics, especially as we think about the Inflation Reduction Act that came into play last August through the Biden administration. Wendy, again, not in life sciences, just a better understanding of how things that are happening will impact people on a daily basis. Yep. And I imagine, Wendy, when certain things happen that may necessitate new infrastructure and buildings, there probably is a need for more cement, which would impact you all. And we'll take one more here, Stan, hoping to hear about impact of AI. Yep, so we definitely see a lot of impact of artificial intelligence, machine learning, especially as we look at NLP, things like natural language processing, to really get better patient outcomes. So wonderful. Appreciate everyone jumping in there. And again, as we go throughout the session, please come off mute, raise your hand virtually, electronically, and Zoe, Keith, just if you can, please help me monitor those different dynamics in the chat feature. So we'll start with the key trends. And Zoe, I did tell Keith if it's beneficial, I can probably put a watermark on these and send it out to you should you want to disseminate it to the group, as long as you just keep it to yourself. So as we look at market research, what we've done is we've curated it and put it into 4 major market drivers. I'll talk about those and then maybe touch off on some of the market drivers, or rather trends over to the right. So the first one is healthcare economics. And we'll see a slide in a few minutes looking at the growth of healthcare as a percentage of the gross domestic product spent in the U.S. Market here today. Today, it represents nearly 18% of the GDP. And is that good or is that bad? Well, that depends. If you believe organizations such as the Bill and Melinda Gates Foundation. Now, I grew up in Seattle, so I don't know if it's Bill's or Melinda's, but let's call it the Gates Foundation. And or if you believe the WHO, the World Health Organization, 2 entities that, really monitor healthcare, patient outcomes, looking at socioeconomic dynamics. So they both say that we're number 1 in spend in all 292 countries across the globe, but we're 31 and 35 respectively in patient outcomes. Now, when it comes to acute conditions, U.S. is, if not number 1, top 2 or 3. But when it comes to chronic conditions, I think that's where we that's where we do fall short according to the metrics they use. So number 1 in spend, in the 30s in outcomes. And again, that has doubled just in the last decade. And again, that's projected to get higher as we look at the GDP. Now, when we spend money on that, that means every dollar on healthcare, we're spending less money maybe on infrastructure or education. So I'm not here to argue what the right percentage is. I just wanted to state what some of the facts are. And again, this is according to the Congressional Budget Office out of DC. I'll go through the bullets on the economics and then I'll pause. What really scares our friends in DC, which really shapes a lot of the health policy, is that second bullet. 3 years ago, for the first time ever, we in the US on an individual, let's call it per capita basis, broke the 5-digit mark, over $10,000 per person per year. That's projected to grow in 2026 to 16,000. So as Keith said, married with 3 boys, a family of 5. That's nearly $90,000 for our family in Schwenksville, Pennsylvania. And if you just do that math times the 332 million Americans, that's really scaring the government because we don't have all these funds. And so when you see that curve increase in spend on a per capita basis, that really triggers a lot of the health policy. To boot, number 3, and this is not the craft cocktail that you're going to see at the Great American Pub in Conchie here in the next couple of weeks, but the silver tsunami refers to the boomers. 10,000 boomers, right? People that age in at age 65 into Medicare. There's 10,000 of these boomers coming in every day until the year 2030. Now, of course, painting a broad brush, the older you are, the more healthcare resources you consume, which is really driving that second bullet, right? So again, these are some of the economic underpinnings driving this. The interesting fact is sometimes in healthcare, we use the term 555, and that is that 5% of members, right? So if there's 100 people in a health plan, 5 of those people drive 55% of the spend, right? And it's these people with these massive comorbidities. They've got a body mass index, which indicates your level of obesity, right? So they've got a high BMI. Maybe they smoke, maybe they've got asthma, maybe they've got type 2 diabetes, and now they've got a little chronic kidney disease. So you've got this small percentage of members or patients that drive a disproportionate share of the spend, both medical as well as drug. In fact, if you look at the high cost claimants, right, these might be people that have children or themselves that have hemophilia, or maybe they've got rare blood disorders like IVIG, or maybe they've got rare genetic diseases like Gaucher's. So you've got this really small percentage that's really driving a lot of the spend in today's healthcare market. As we think about specialty drugs, so when Keith and I started in pharma in the 90s, we would get pushback from physicians that we would have this expensive antibiotic that may be $350 a month. And I'm not saying that $350 a month is not expensive for certain families or individuals, but compared against today, when I work with companies like Novartis, not far from Carroll, up in East Hanover, New Jersey, that have a drug called Zolgensma, that's $2.125 million, and it's a one-time treatment. But that can now impact your child, where now they're not getting a tracheotomy at age 2. They're not in a wheelchair, and they're actually living past age 5. So now you've got all these cell and gene therapies that are curative in nature. But it comes with a price tag of $2 million. Or just north of us in King of Prussia, you've got a company, CSL Behring, that just came out with a curative agent in hemophilia for $3.7 million, right? So you've got this big onslaught, and you've got a huge pipeline now in phase 3. That means they're about to come to market, and we're all wrestling with how do we handle all these different prices. So just one other comment, and then I'll pause. If you think back, and again, I'm apolitical in today's conversation, so I'm not going to favor either party. But if you go back to the Trump administration, we had the 3 musketeers that came out of Indianapolis. So you had Vice President Mike Pence, came from Indianapolis, or from Indiana. Number 2, you had Seema Verma. Seema Verma was the head of CMS, the Centers for Medicare and Medicaid Services. Right, so we had Seema Verma, we had Mike Pence, and my coffee, Zoe, hasn't kicked in. It will in a minute. We have the third person, Alex Azar. And Alex Azar was an executive at Eli Lilly. When Alex was on the front lawn of the White House, he had talked about what became known as most favored nations. And what he looked at was, hey, let's look at 15 other countries plus the US, and let's come up with an international pricing index model to say, hey, let's come up with a blended cost across these 16 countries to maybe determine a more fair price for drugs in the US market. What Alex said was that, hey, if everyone else paid fair market price, if everyone else spent the money like we do in the US for research and development, where nearly 20% of our revenues go back to R&D so that we can come out with vaccines for COVID-19. We can come up with vaccines that cure polio. We can come up with drugs for HIV/AIDS that now it's not a death sentence, now it's a chronic condition. And he said, hey, if the rest of the westernized world, I'm not talking third world countries here, but if everyone did, it wouldn't be 332 million people in the world creating this great innovation. It would be 862 million. That sense with the Biden administration has been put on pause. But team, those are some of the economics in the US that are really driving healthcare. Zoe, Keith, what I'd like to do there is pause, questions, comments, thoughts, pushback, additional context.
Hey, Ryan, are insurance companies covering those $1 million plus therapies?
Well, Ken, if you were with us August 26th in Ireland, you could hear us talk about those different dynamics. To answer your question, Ken, the adoption in the US market has been minimal. In the European model, ironically, a lot more uptake. But Ken, here's kind of the quick and dirty on it. Let's say, Ken, that you're up in the Poconos and you and your wife have a child. And unfortunately, that child, and this going through pregnancy, through genetic testing, that they are predisposed to spinal muscular atrophy, right? A massive, horrible neurological disease. And so now, Ken, they come to you and your wife, and there's a couple options. So, Ken, good news, bad news. Good news is, for now, the last 7 years, there's now a treatment that can help your child and you and your wife. The bad news is, Ken, that comes with a price tag of $2.1 million. And so, of course, as loving parents, we want to do whatever we can. But hey, we've got a finite amount of resources. So there's companies now, Ken and team, that do a lot of what I categorize them as the entities are SPBMs, right? So we all know about PBMs, pharmacy benefit management companies. Usually health plans reach out to these PBMs to help manage claims adjudication, the paperwork, RFPs to manage drug therapies. These SPBMs can do and team do a lot of work around specialty medications. And so there's a couple like CVS that we all know. And CVS has a medical benefit management company with them called Novalogics. Just up the road from us in Malvern, Pennsylvania, is a company called Acela Health. And so what happens, Ken and team, is let's say that Ken, he lives in Pennsylvania when he's not in Georgia. And let's say Ken's benefit is through Independence Blue Cross. That's a Blue Cross Blue Shield plan in the state of Pennsylvania. What happens is Blue Cross Blue Shield will carve out Ken, his wife, and his child to an SPBM. Let's say it's Acela Health. Acela Health, the SPBM, will now take risk of Ken's child, right? So they'll own the claim on Ken and his wife's child. What'll happen now is Ken will work with an agent from this SPBM. Let's call that person Craig. Craig will do a direct contract with Novartis, and he'll procure that drug from Novartis. He will temporarily take on the risk. Then what he'll do, Ken, is he'll work with a bank either in New York or Connecticut. And what he'll do is he'll set up a drug mortgage. So just like Ken, you've got your second home in the Poconos, your third home in Atlanta. Now you've got to take out a mortgage for your child to pay for this drug. Now, the good thing is, besides Ken, who can't afford a $2.1 million drug, many people can't. And so now you're changing the episode of care from a one-time sunk payment that would put a lot of people, in hard financial hardship. Now it's a little more palatable because they're setting up a mortgage, right? So instead of paying for a second home or a boat or whatever it is, you're paying a monthly payment to a financial entity to get that drug for your child. Now, a couple other comments, Ken, then I'll pause. Because of that high cost, they're actually setting up guarantees. And so the challenge is there a clean, clinical, auditable metric for that drug? For spinal muscular atrophy, Ken and group, there is. In fact, there's 2 of them. And they'll say, hey, Ken, we're going to forgive your loan if at age 2, your child is put on a tracheotomy, right? Something to help them eat and breathe. If that happens, Ken, we're going to forgive the loan. The drug didn't do its job. We're not going to charge you. The second one, Ken, we pray to God this doesn't happen. If that child happens to expire and pass on, they die at age 5, Ken, we're going to forgive that loan. So those are some of the dynamics going on to pay for these multi-million-dollar drugs.
Wow. Even so, even with that, it's hard to imagine a lot of people are going to be able to afford that, adding another mortgage cost to their life.
Yeah, agreed. And so that's where these SPBMs, along with advocacy groups, really do a great job of scouring additional funds for patient assistance. So they go to several different advocacy groups. Of course, they go to the manufacturers, patient assistance. So it's not like, Ken, to your point, because even I don't, even think about mortgage on 2 million. That's still a ton of money. So they weave in a lot of other programmatic support to drive down that payment.
And is that the same? And then I'll stop. In ex-US or in Europe or?
Yeah, so it's interesting because you think about most countries outside the U.S. I guess South Korea would be the exception. South Korea is very similar in healthcare to the U.S. market. But let's take England. The UK. We're going to be talking about NICE later on today. But you could almost categorize them as a single payer system. If you really understand the UK market, it is with the caveat that they outsource to a lot of third-party entities to help manage healthcare, right? So we're working on a project right now with the prison system within the UK, which, the prison system is almost a separate version of long-term care. And so you think about all these prisoners, be it in the UK or US or pick your country, and a lot of them have HIV, right? And they're then co-infected with hepatitis C. And so that necessitates curative therapies, that are also not inexpensive, right? The agents from be it AbbVie or Merck or Gilead are $50,000 to $96,000. And so there's been more receptivity in markets like England to use these drug mortgages so it can free up capital so that they can treat more patients because you're stretching out that payment in episodes of care. Thank you, Ken. Team, other questions on the healthcare economics that we covered here in the first few minutes? And Keith, just help me if there's anything in the chat feature that I'm missing. All right, so I'm going to jump. Okay, cool. I'm going to jump down to payer consolidation, payment models, and I'll come up to health policy again after each subsection. I'll pause, and then I'll get into more granular detail as we jump past this slide. So I want to come down to payer consolidation. Let me grab my annotation feature for a minute, because I know not everyone can read font size 2. So as we're looking at payer consolidation, you'll see a slide here in a minute. In just the last decade, with mergers and acquisitions, it's really created this vertical integration with really 3 major entities really holding the power. Now, what does that mean for a life sciences company? Let's say that for a minute, if Carol and Stan worked at that little $88 billion machine, Johnson & Johnson, and even though that J&J is influential in its own right with its robust, diverse portfolio, but now all of a sudden with these 3 big payers, think about organizations like United Healthcare that also have their own PBM Optum, they have their own specialty pharmacy Optum, that also have their big provider groups, right? So you get one of these big 3 and they come to Stan and Carol and say, hey, Stan and Carol, if you want your drug covered, reimbursed, so that when the patient goes to the pharmacy, the copay is not so ridiculous that they abandon the therapy and say, hey, give me a generic, right? So Now, because these three big payers have such large influence, they can, if you may, squeeze pharmaceutical companies for a higher rebate. So, Carol, if you want your drug covered, reimbursed on the formulary without a lot of what we call utilization management, not a lot of restrictions, Carol, you're going to have to give me a rebate. I'm just going to use a simple number of 60%, right? And so think about Carol, or think about, I'm trying to think who is the person, I think it was Wendy that may be in the concrete business. And so, Wendy, think about for every $100 of concrete you sell, I imagine there's certain operating expenses, right? And eventually you've got your net income and you've got your gross profit margin. And if you're a public company, ultimately you've got your EBITDA, right? What's the earnings before income tax and depreciation? And so every dollar that you put into the expenses drives down that profitability. And so if you have to give a 60% rebate right away for every $100 you're receiving in revenue, 60 cents on the dollar is getting lost because you have to give that in the form of a rebate. And so with this massive consolidation, just like any market, right? Think about in consumer packaging goods, the power an Amazon can wield or a Walmart can wield. And so that's a major implication for pharma with this M&A on the payer side, is they can now squeeze pharma for more rebates. So that's a dynamic going on there. I think that's a big enough of a bullet, Keith and Zoe, where I'll pause there real quick before I hit the other bullets. I'll get to a slide here in a minute. I just mentioned one of the big three, United Health Group, Optum. They've also got now a payer, GPO, over in Ireland. I will take a minute to talk about that. If we go back to the Trump administration, and you would think that being a Republican, and typically Republicans were more favorable to pharma. However, interesting, in that administration, they started to really call out what they called the middlemen, these PBMs, the pharmacy benefit management companies. And what the Trump administration said was, hey, we want to make these rebates that drug companies pay to make sure their drug gets access on formulary. We want to make these rebates illegal. Now, if you understand the flow of a dollar and you understand how a health plan makes money, there's really three revenue sources how health plans make money, right? So United, Aetna, Anthem, Cigna, Blue Cross Blue Shield, of pick your state. So number one is premiums, right? Say Bob Arnold is what they call a member, right? We call patient, he's called a member, and Bob pays a premium, right? And so all those premium dollars come into the form of revenue for a health plan. The second piece is drug rebates, right? Health plans can make hundreds of millions of dollars every year collecting rebates from drug companies, right? So that's number two. Number three is through quality metrics. So the better a health plan does in quality metrics, right, getting better patient outcomes, if they have Medicare patients, they can get millions of dollars through remuneration through getting good quality metrics. So you got three revenue sources: premiums, rebates, quality metrics. If one of those revenue sources gets impacted, in this case, rebates, guess what's going to happen to voting constituents? Their premiums are going to go up. So that's when they said, hey, we're going to pause that idea. But as a contingency plan, what happened was this scared the bejesus out of these health plans. And they said, if that happens, hey, why don't we go overseas, different tax laws, and we're not going to have a PBM. We'll start up a GPO, a group purchasing organization. As long as you have two customers, you can call yourself a GPO. And so they said, hey, we can safely harbor these rebates overseas, but we're not going to call it a rebate. We're going to call it an administrative fee. And that was the birth of what these payer GPOs are over in either Dublin, Ireland, or Bern, Switzerland. So that's where some of the big three have gone. PBMs. As we think about that, let's say that Ben, what part of the country do you live in? Ben Pastro?
I'm in Wilmington, Delaware.
All right, Delaware. So obviously from a healthcare system, you've got like the Christianas of the world. I think you've also got your own Blues plan with Delaware. And so what happened a couple of years ago, Ben and team was, let's say Ben is a director of pharmacy for Blue Cross Blue Shield of Delaware. And Ben's got 5 full-time pharmacists, right? And Ben's got to pay them, let's say $250,000 a year in salary because they're very smart PharmDs. They've got their doctorate in pharmacy. Plus Ben's got to pay them benefits, right? Usually benefits are 25, 30% of your salary. So let's call each full-time equivalent 300,000, and Ben's got 5 of them. That's 1.5 million, right? That's a big hit to Ben's bottom line. And to boot, Ben and his team are spending a lot of time going through all these requests for proposals, managing them, trying to collect money from pharma. So then all of a sudden what happens is Stan, right? You got this wicked smart guy, engineer with a master's from Stanford, living the dream in Westchester. And he comes to Ben, right? And Stan works at a PBM and he says, hey, Ben, how much did you get last year in rebates? And I'll use simple numbers. Ben says, hey, Stan, I got $100 million. Well, Stan says, hey, Ben, tell you what, if I were to give you 5% increase right off the bat, right? So now, instead of making, you're getting 100 million in rebates, now I'm going to give you 105 million. And by the way, Ben, since I'm going to take all that workload administrative burden off your team, you can probably let go of 3 of your pharmacists. And hey, that saves you another $1 million. So Ben, you can go to your boss, your chief financial officer, and say, hey, I've got a new solution. I just made $6 more million that goes right to the bottom line. Ben looks like a hero to his boss, Wendy. Now, what's happening is over time, the PBMs aren't passing on all the rebates that they're getting. But what's happened is over time, these health plans, fewer and fewer, in fact, there's only 5 that do direct contracting with pharma companies. It's now being done through these big PBMs. And there's about 3 PBMs that are managing over 80% of all these contracts. Again, giving them a lot of negotiation power. So these are some of the economics. We've got 3 wholesalers, again, driving over 90% of the business, a different supply chain, everyone trying to pick off a little bit of their money and revenue. And then a really interesting dynamic over the last decade is changing the model with pharmacies. So if you're in Pennsylvania, maybe you've heard of Geisinger. It's a health system that has a provider network and a lot of hospitals now in 8 different states. And in the past, pharmacies were seen as a cost center, right? They would charge money and the drugs would be a cost center to the P&L. But what happened was they said, hey, what if we open up our own specialty pharmacy where we can charge a high amount just to fulfill the prescription? And overnight, they went from a cost center to now a profit center. In addition to filling a drug, when they filled a HCV drug, they would get $10,000 just for fulfilling the prescription. Now they've got really good data, right? Because they've now captured, retained that patient. And now they've got longitudinal data they can sell to pharma and other companies. So team, those are some of the dynamics that we see via payer consolidation. Zoe, Keith, let me pause there for people to ask questions either directly or via the chat feature.
Ryan, has there been any impact of, I guess, more of a focus on preventative medicine versus treatment? And is that having any impact on the cost of healthcare?
Absolutely. So, Ken, if we were to jump back to my previous slide and look at evolving reimbursement models, we've seen a big shift from reimbursement for services to reimbursement for quality medical outcomes. And so that's why we've seen a host of quality measures. You see quality measures such as CMS, right? So they've got a program called STAR measures. They've got 53 measures that measure quality. They've got things like NCQA HEDIS, Accountable Care Organization. So Ken, to answer your question, there's now over 1,461 quality measures to try and get better patient outcomes. If you were to look at those quality measures, Ken and team, they really fall into 4 domains. And Ken, one of them is prevention, right? So, hey, how do we do more breast cancer screening? How do we do more colorectal screening? How do we do more prostate cancer screening? How do we do more screening to see if someone's rising risk and there may be starting to see an increase in their hemoglobin A1C level that may trigger them to be a diabetic that's going to bring on a host of costs. So we're definitely seeing that in quality measures. And then, Ken, what we're seeing is that push down to providers. And so now it's, hey, Dr. Ken, you're part of now Lehigh Valley Network. And Ken, part of your compensation is we're going to have a scorecard on you, Ken. That is, how well do you do monitoring these patients with rising risk? And how do we mitigate that, treat them now so that they don't become one of those high cost claimants? So we've definitely seen, Ken, a big shift to prevention. But I think to our friend, I can't remember, was it Stan that was working on gamification, or Jeff working on gamification? Even in a disease state where like liver transplantation or organ transplantation, you would think that people would be 100% adherent to therapy when they've been on a waiting list for 4 years, they finally get an organ, and now it's critical you take a drug to help your body accept this foreign object, an organ. And people still are not 100% adherent to that. So yeah, big push to prevention, Ken and team.
So Ryan, you talk about the consolidation. Is there any checks on that? Like, is it just a free for all in terms of consolidation, or is there government oversight, or why is that happening? And if there is government oversight, I'm just naive to what even would control that.
Yeah, definitely government oversight. As we look at the Federal Trade Commission, they'll look at, even within pharmaceutical companies, if you go and, Keith and I always joke, one day we're all going to work for Pfizer, we're going to fly American and stay at Marriott, right? And so when a pharmaceutical company merges, when a health plan merges, in a tech world, when you get telecom, they're supposedly looking for the end user, in this case, the patient, the consumer. And so what they don't want to create is an oligopoly or monopoly where that puts the patient, the member, at undue fair advantage. So government oversight is definitely in play. Now, I think the value proposition that they put out to the government is this is better for the patient, right? To Ken's point, hey, there's going to be better prevention, better patient outcomes, which can decrease the total cost of care for everyone. But I think, Zoe, you and I live in the city of brotherly love handles, and we've seen that our cost in airfare with American has not gone down besides the pandemic. It's gone up. So even with the government oversight, I think if you go 2, 3, 4 years out, I think we've still seen, even scrubbing away CPI, that the price does go up. But there's definitely a lot of oversight looking into those dynamics. All right, the third piece, I'm going to bring your eyes to the bottom of the screen here. Let me grab my annotation feature here. And as Ken said, hey, Ryan, as we look at prevention, what's going on there? Things like prevention, other dynamics have really triggered these evolving payment and service delivery models. So I'll talk about quintuple aim in a few minutes. But, as we look over in the UK, they're much stricter in their formulary in drugs they cover and do not cover. And so they have hardline metrics. What they'll do is they'll say, like, hey, John, or, hey, Stan, hey, Carol, what are we getting? What's the value we're getting for these new drugs? So they'll look at things like, well, hey, if we take this drug, and let's say now Carol's administering it, is my patient or my constituents in our market, are they going to get a better value, right? So they'll look at what's their quality of life. Maybe they have multiple sclerosis. And do I want to pay $80,000 a year to give them this drug therapy? Well, if I do, what's going to happen, right? Is their quality of life better, right? Are they more functional, right? Did they go from being sedentary at home where they couldn't get up, get off the couch and go to work? Well, hey, now with this modality, this drug therapy, their quality of life is better. They can get up. So they're interacting with people. So maybe they're not depressed because now I got to treat depression. Maybe they're back to work. So their absenteeism has gone down. They're a productive citizen. They're functioning and they're, part of the big machine back to work. So these are different dynamics that markets in the UK with organizations like NICE look at. And so there's a big push around healthcare economic information. What they're saying is, hey, your clinical trials are not real world, right? Not everyone's sitting around a lab, going in at 4 p.m. every day to get their drug. It's not a controlled environment when we go back to the Poconos, when we go to Basking Ridge, when we go down to Delaware, right? All of a sudden, Ben's over at Letty's eating some of the best fried chicken in the U.S., and maybe he skips his therapy because he's going to a Blue Hen game. And so what they're looking at is, hey, let's now look post clinical trials, and let's look at people like Ben in real world settings. And now, what are those outcomes that we're seeing in patients like Ben in the great state of Delaware? What's that real world data? And what is the evidence telling us? And now, pharmaceutical companies, if you want to put your money where your mouth is, let's tie drug outcomes to the real world evidence that we're getting. And if we're not getting the outcomes that you proposed in your trials and real world evidence, then we don't want to pay as much for that drug, right? We're going to pay 100% minus 10, 20, 40, 50%. Or an example I gave with Ken, if we don't hit these metrics, we're not going to pay anything. So these are some of the different payment models that are really changing the go-to-market strategies that we see from life science pharmaceutical companies. Team, before I go to health policy, again, let me pause there for questions, comments on different evolving payment models.
It's Stan. So if an organization is what I would call self-pay, for example, I don't know if J&J does that, but I work for J&J, and I suspect their healthcare costs are big enough that at some point they take some of the risk, and they then I'm not sure what the right word is, but they basically kind of collaborate with an organization such that the largest risk is outsourced in some way. Does that change things in some way?
Well, here's how it answers. Here's how it changes things, Stan. So what Stan's talking about is in the healthcare world, there's two types of entities, if you may. There's fully insured, right? So think about, as Stan said, J&J, $80 billion plus organization, probably over 100,000 employees. So they are large enough where they can say, hey, Horizon Blue Cross Blue Shield, New Jersey, because we're large enough and we're influential enough, and we're probably one of your major customers, we're going to take on the risk ourselves. And Mr. and Mrs. Health Plan, all we want you to do is we want you to administer the services, right? We're going to take on and absolve that risk, right? So in that model, J&J can sign up with a health plan and say, we want to be an ASO entity. All we want you to do is administer the services. Or they can be what they call FI, fully insured, right? And that's to Stan's point, taking on, well, hey, we're going to take on all the risk. So in those two examples, if they're FI or ASO, a J&J could say, you know what, because we're large enough, we want a custom medical benefit. We want a custom pharmacy benefit design for our J&J employees. Now, if you're Stan Telson Inc., and he's got 3 employees, Stan doesn't have that negotiating power to have a customized medical policy or pharmacy benefit for he and his 2 employees, right? So then Stan has to acquiesce to the plan that he and his 2 employees sign up for. I don't know if that makes sense or answers your question, Stan.
Yeah, it does. But do any of these dynamics change? I mean, I understand that structure and that makes sense. But do the dynamics change when an organization is self-insured? For example, I remember working for, and I forget which company, but they had a catalog of pharmaceuticals, and they had somehow carved out their pharmaceuticals with no copay. So they were able to do that by designing their own plan, I guess. Is that the kind of thing that happens?
Yes, yeah, like when Keith and I worked at Wyeth Pharmaceuticals, here's a shocker, all Wyeth drugs, to your point, Stan, had a $0 copay. Think about a company like Novartis or BMS that's headquartered in the state of New Jersey. Guess what? They have pretty good access to those health plans like Horizon, because that's one of their critical customers. And they have medical benefit and pharmacy benefits that are aligned to their portfolio. So absolutely. Thanks for the question, Stan. Team,
Thank you.
anyone else on either evolving payment models or anything else that we've covered to this point? All right, I'm going to jump us up to health policy, and then I've got some subset of slides to get into a little bit more detail. Again, I'll grab my annotation tool here, grab my spotlight. Here we go. So we're talking government health policy. Of course, just a few months ago, we had some elections. So the Democrats still have the broader party control as we look at the Senate, the House, and the White House. But we did see some changing of the seats with Democrats, Republicans. So, the challenge is, regardless of what party's in, people will come in based off their positioning to their constituents. They'll put some things in motion. But we know then when it comes to the House or the Senate, you've got to get the vote. Even when it passes, it then takes a long time to get approved, right? Go back to the most favored nations model. That was put into a motion, approved, and then you get a new administration put in. So a lot of these things, I think, are to get votes, to get the attention. But the ones that actually have a true downstream impact are smaller in nature. Let's take IRA. August 16th of last year, the Biden administration put in the Inflation Reduction Act of 2022, right? A lot of things, and it didn't just affect life sciences, pharmaceutical companies, and drug prices, right? It affected several other facets within our U.S. economy. But as we think about pharmaceuticals, the first pieces aren't really set to go into motion until 2026. They're already starting to talk about a list of 16 drugs that the CMS, the government, Medicare, is going to negotiate with pharma for a much lower cost. But here we are in 2023. We've got some major voting that's going to happen between then. So who knows if that actually sees the day of light. But it is triggering contingency planning and thoughts and conversations today. As we came through the COVID-19 pandemic, that really underscored a big piece around what's called SDOH. And as we think about that, social drivers of health, if nothing else, COVID did really underscore that. You think about states like Pennsylvania. If you go outside of Pittsburgh to some of the rural areas, maybe not everyone has the means to get to a specialist or a healthcare provider, a primary care person. So maybe as Jeff is working on gamification to drive adherence, Jeff's got to think about in that equation, social drivers of health. If someone can't access a bus or transportation, an Uber, a family member to get to UPMC in Pittsburgh to get their infusion therapy, they're not going to be adherent to therapy. We worked on a project in Delaware around HIV/AIDS. If you have poor dental care and you need to take your medicine along with food, and if your dental care is such that you don't have teeth or you don't have enough teeth to chew properly, to consume the medication and food, you're not going to be adherent to therapy. If you live in lower, slower Delaware and you can't get to your infectious disease provider, that's going to drive down adherence. So there's been a big focus on social drivers of health so that we can get these different outcomes. One of the biggest challenges, two more bullets and then I'll pause, and then Keith, Zoe, monitor chat for me, is the Great Resignation. If any of you watched 60 Minutes a couple months ago, they had 3 CEOs from major healthcare systems. Their big issue was staffing, right? When people come in the door, they don't have enough FTEs and staffing to treat these patients, to triage them, or to treat them in the respective service lines to drive down costs. The other big thing for pharma is you look at their P&L, one of the major items driving down their profitability is the 340B drug discount program. If you don't know about 340B drug discount, we can't capture it all today. If you're really interested, you can go to the website of Apexus, like Apex US, APEX-US. That's a big 340B group purchasing organization out of Texas, and they've got all that you need to know on 340B. The quick and the short on 340B is it was born to provide access to drugs for patients below the federal poverty level. So certain hospitals that had a disproportionate share of people under that federal poverty level, they could say, hey, you can go to the Bob Arnold Hospital and the Bob Arnold Pharmacy because they qualify based off the economics in that zip code or those zip codes. They're now granted 340B drug discount pricing. So Bob, as a director of pharmacy at Hospital X, he can buy the drug from Jeff for, let's say, 22 cents off the dollar. And now, ideally, Bob will pass on those savings of 22 cents on the dollar to his patients. What's happened is now Georgianne, Jeff, and Wendy say, hey, Bob, can we piggyback on your 340B status? Can we buy drugs at 22 cents off of wholesale acquisition cost? And now Georgianne, Jeff, and Wendy aren't passing on all 22 cents of the savings. They're keeping a lot of those pennies. That's now a revenue stream for them. And so there's been a massive misinterpretation and adoption of truly what constitutes a 340B entity. That's driven down to profit margins for pharma. And so there's a lot of policy and legislation trying to address that. Keith, Zoe, those are some of the health policy dynamics relative to pharma and healthcare. Let me again pause there. By no means am I a health policy expert. I'm, if you may, a deep generalist, but I'll do the best I can to answer any questions you may have. So, team, I mentioned earlier, nearly 18% of our gross domestic product is spent on healthcare. You can see on the slide here over the last several decades how that has grown. Even if you go back to the 1940s, if any of you ever have heard of Kaiser Permanente, Kaiser Healthcare, 90% of its life's out in California, northern, southern. Now they're in about 8 states plus the District of Columbia. And if you think back to the roots of Kaiser, it started with Henry Kaiser. He was there in the great state of California, and he had the Henry Kaiser shipyards. Think back to World War II. He was helping build ships as we were going to war. And as you think about the early 1940s, for any of you economists, you probably remember from your history books, there was a wage freeze going on, right? So they froze the fees they could pay laborers. So what Henry Kaiser did is he said, hey, I can't give you more of a wage. What I can do is I'll give you free healthcare. And he could do that because in the early 1940s, healthcare wasn't 18% of our GDP, it was 2%. And you can see how that's grown over the years. And that's why there's all this talk in politics and why, for some reason, pharma has got the bad rap. Now, I am biased to pharma, but I will say, hey, look at the innovations that we've got, how we've nearly eradicated things like polio or river blindness. Think back to the pandemic with the quick pace that we got these vaccines. Think about conditions like HIV/AIDS or COPD or cardiometabolic disease, and think about how now that's truly a chronic disease. And hey, by the way, if you don't want to live longer, you also have the free right not to take these medications. Think about all of the great jobs it's created across the US. So again, offline, if you want to argue those dynamics, but I would say that the healthcare industry has great innovation, has really done great things for the American consumers. And of course, to get a generic drug, you need an originator drug, right? And so a lot of these meds after 7, 12, or 18 years have become generic. And now you can get those drugs for pennies on the dollar. Those wouldn't be available if it was not for the originator. Oops. If you look at that 18% of our healthcare, that translates into $4.1 trillion. That's what we spend on healthcare in the US. Now, you would think, based off commercials during voting season, that 90 cents on the dollar would go to drugs. But as you look over here, 31 cents on the dollar is hospitals. Then you've got 20% going to physicians, and it's 8%. It's actually closer to about 11%. It says 8 here percent because that does not include all the part B as in Bravo drugs that get buyed and billed, right? So there's 3% from this 20 that physicians buy and bill that could come over here. But still, that's 11 cents on the dollar that go to drugs. That means 89 cents on the dollar is not spent on drugs. And what pharma companies would like to tell us, and now we're seeing that in real world evidence, is that, yeah, even if you do spend 11 cents on the dollar, you'll see a medical cost offset, right? Stan, if you spend $2 million on your child to treat their spinal muscular atrophy, yes, that's a lot of money, but we are changing the episode of care through a drug mortgage. But Stan, that patient is now not going to the hospital every week, right? They're not getting readmitted for flare-ups, and that's at a tune costing $110,000 every time. And by the way, that's a lifetime, right? So what pharma is trying to do, expressed through real world evidence, is talking about the total cost of care. Yes, you're going to spend 11 cents on the dollar up front, but what you're going to see over time is that total cost of care is going to go down because that disease state condition is being treated better, and or we're curing it. So those are some of the dynamics as we look at how the healthcare dollar is broken down. I'll go through a couple other of these and then I'll pause. As you look at the different sites of care, that 4.1 trillion, you can see in the inner concentric circle, how much of that comes from employers versus Medicaid or children's health programs or Medicare, or even things like Indian Health Services or the VA DOD. And then the outer circle gets into, well, hey, are they getting treated at hospitals or infusion centers or ambulatory care? So these are the different sites of care and how that dollar's spread. We talked about that silver tsunami earlier. Again, all these boomers coming into the market, really affecting things until 2030. We talked about some of those high cost claimants, that 1.2% really driving a big portion of the spend. And again, that cell and gene therapy, drugs that are $2-3 million, that's really driving up the spend. And how are we going to address this as a society in the US? And that's, triggering some of these drug mortgages, bridge loans, and other dynamics. Now, we use the term loosely, payer in the US, but there's really 3 entities that pay for healthcare, right? So you've got the government. So if you're below the federal poverty level, if you're an individual, I think it's $14,632. If you're a family of 4, I think it goes up to maybe $74,000. So if you're below federal poverty level, you qualify for Medicaid. And sometimes you can get drugs for $0 to $4, right? Your copay to see a provider can be $0 to little dollars. Or if you're Medicare, typically, right, 98% of the time, that means you're age 65 or older. Now you've aged into Medicare. However, I work with patients that have like sickle cell disease. And if at age 18, you can enter eligibility for Medicare. Usually it takes about 24 months. And if there's a lot of other dynamics in that entry form, I've seen a Medicare patient as young as 20 years old. Mostly they're 65 and older. You also have these dual eligible patients. They qualify for Medicaid, Medicare, right? So they're not 65, but maybe they've got end-stage renal disease and they're below the federal poverty level. And so they're what they call a dual eligible, low-income subsidy eligible, and they get loads of benefits, right? And not getting into politics, but hey, for these people that have that kind of debilitating diseases and they're not functional and can't get work, I'm okay with my tax dollars going to those kind of people, right? For someone that's able-bodied and they make more money sitting at home than going to work, for me personally, that's a different conversation. Then you've got the VA and you've got the Department of Defense, right? And that could be your active military or your, you put in your X amount of years, and now you can go to any one of the VA hospitals spread throughout the 18, what they call VISNs, kind of groups of VA hospitals throughout the country. And then like when I lived in Arizona, close to the Navajo Nation, you had like your Indian Health Services, right? So the government pays about 62% of healthcare today. Now, everyone calls health plans and PBMs payers, but it's really the employers, right? It is J&J, it's BMS, it's Aramark, it's American Airlines, it's whoever that employer is. But what they'll do is they'll use intermediaries, health plans and PBMs, to manage their medical and pharmacy benefits, right? So they'll use them to manage their spend. And then you've got people that don't have benefits. Maybe they don't qualify for Medicaid. You got these young invincibles that are 27 years old. Nothing's going to happen to me. And I don't sign up for a plan and I'm just going to pay cash as I go along. So those are the three standalone pillars, if you may, that truly pay for healthcare, but there's different entities that help them do that. I'll cover off on just a couple more and then we'll pause here on some of these dynamics. Again, these are some of the dynamics, and you can see the number of drugs that are in orphan, rare, ultra rare. When we say orphan, rare, ultra rare, right, it's not diabetes that affects 8.2% of the patient population in the US, right, nearly 40 million people. These are small groups of people, right, that may only have 100 patients, 200 patients, less than 2,000 patients in the US. So much smaller pockets of populations, but the cost of that modality and treatment is very, very expensive. Keith, Zoe, it's 9:11. I know we've got 20 minutes left. I'll give you guys at least 5 minutes at the end. Before I jump into a few more details, let me pause there for any of the slides I just covered here.
Yeah, I'm curious. You showed that first pie chart where it was 8 or 11% going to pharmaceuticals. How is that changing significantly over time?
What's happening is the overall increase in drug prices relative to inflation is relatively flat. Where you're seeing the big spike is in these specialty medications, the rare disease. But to answer your question squarely, whether it be 8 or 11%, that percent is not increasing as much as it is for hospital care and physician services. So that 8 to 11% has been relatively flat for the last 3-4 years.
I see. And then kind of following on that, in most areas where technology is driving activity, you end up seeing costs go down, either costs go down or services increase for the same cost. And I would think that with drugs gradually migrating to generics, I mean, there's, patents take 20 years, so it's not overnight. And with new technologies coming out, that they should be reducing cost rather than increasing cost. But in pharmaceutical, or not pharmaceuticals, in healthcare, we're seeing the opposite happen. I'm wondering what your speculation is as to why that is kind of counter trend.
Yeah, to Jeff's point, as you talk to a chief medical officer at a health plan, their big focus is total cost of care. And so if Jeff came to me with some new technology, right, maybe now I've got a curative agent, we should see that total cost of care go down with this advancement in technology. But Jeff, I'll talk technology for a minute first with drug therapy, and we'll go back to the example I've given with spinal muscular atrophy. And so there's three pharma companies that play in that space: Novartis, Genentech, and Biogen. But what we're seeing, Jeff, is when pharma comes to the table to say, hey, we've got this new technology, Jeff, this new drug that's curative, we're not seeing that durability. So a cure is not a cure. What we're seeing is breakthrough that, hey, now 4, 5, 6 years later, now that patient is presenting with clinical symptoms where they're not cured. So now we need to add on another technology, another agent. And so we're not really seeing the durability of these new technologies, at least in drug therapy, expressing the evidence that they are professing to do. Now, another piece in technology, Jeff, that we've seen, as you mentioned, machine learning, artificial intelligence, and I think it was Stan that talked about prevention. We've seen a lot of NIH, companies like Eversana, companies like Premier, the GPO with their arm Pink AI, doing a lot of natural language processing. So outside of ICD-9 and 10 codes, they're going in with a lot of language, and they're capturing that through machine learning to do better predictive analytics so they can capture those patients with rising risk. They can prevent and try and capture them sooner in the patient journey so that they can treat them more aggressively now to mitigate some downstream costs. So, Jeff, I think we're seeing in pockets of the country adoptions of technology, machine learning, artificial intelligence, natural language processing. And I think we're still in the infancy of seeing that real world evidence, but a lot more adoption thereof. The other piece in healthcare, and so forgive me, there's no connection over to the cement industry or industrials here, Wendy and Carol, but for those of you in the healthcare sector or just as consumers of healthcare, I do want to bring to light quintuple aim. Maybe many of you heard of quadruple aim or even back in the day, triple aim. Back in 2007, a gentleman by the name of Don Berwick left the Institute for Healthcare Improvement and came over to lead the CMS. And at the time, the Obama administration really liked his vision. And so what Don did was really, that was the genesis of the triple aim. And what he said was, hey, my view of healthcare in the US market, I think there's three dynamics that can really change the total cost of care and the outcomes we get in the US market. Number one, we need to improve the health of our population. And that goes back to Stan's point. How do we do better prevention? How do we get better outcomes? And that really triggered all of these quality measures that we see out there today. So, hey, we're going to pay you more for better patient outcomes to get better population health. The second thing Don said is we need to really improve the patient experience, right? People go to physician offices, ER hospital, it's miserable, right? It is not bueno. So how do we change that paradigm and have a better patient experience? And if we can do that and reduce or manage the spend on a per capita basis, man, that's going to really transcend the healthcare in the US. Now, fast forward 7 years later, shocker, we didn't see those outcomes get realized. And so he said, I think the missing link is now integrating in the voice of the provider and the caregiver, right? Let's be honest. If you have a family member with Parkinson's disease, it's a caregiver or a family member that's really helping drive that patient experience for them. So how do we bring them into the mix? Fast forward 7 years later, 2021, in the pandemic, now we see how important social determinants or social drivers of health are. So what pharma companies have to do in conjunction with payers, health plans, systems, centers of excellence is number one, how do we improve that patient experience? Right? For those of you in pharma, you know, they use things like HCAHPS or Net Promoter Score. So how does our drug, how does our program, how do our services improve the patient experience? If they can't do that, the second ask for a pharma company is, well, how does your product or your program improve the health of this patient population? That's where we've seen companies like Eli Lilly and Novo come out with programs to improve diabetic patients' outcomes, where more patients are controlled under a hemoglobin A1C of 7 that's not triggering ER visits and driving up maybe downstream dialysis, total cost of care. Now, the real world evidence is, okay, hey, by adding your drug, what's that going to do to my spend? If I add this new MS modality, like an Ocrevus from Genentech, what's that going to do in managing the total cost of MS? I think that was might have been Ben asked a question about total cost of care. The challenge for a payer is that what they call members, or what we would call patients, they only stay with the employer 2.2 years. So imagine one of my patients has HIV/AIDS, or let's say hepatitis C, and I've got this treatment that's going to cure him, but it costs me as a payer $96,000. And then my patient Ryan, 2.2 years later, leaves me, and they go to Carol's plan. Carol gets the benefit from the $96,000 that the other plan just paid, right? So they're talking about a healthcare coin model where, hey, if I pay that $96,000 as a plan, how do I retain some of that payment where I get to realize the benefit of curing that patient, even though they've gone to Carol's plan, right? So these are some of the challenges that we have to wrestle with in our market. And then, hey, does your product, your program, your service, does it drive a better patient or provider or caregiver satisfaction? And then the last piece is, hey, how are you part of the solution in identifying these social drivers of health? So that's what we always ask pharma to think about, their value proposition. How many of these different facets relative to quintuple aim can you touch on? The more you can, the more differentiated. The more differentiated, it's not just rebates. Now it's you've got you can sell on a basis other than just price. Team, any questions, comments, thoughts on the quintuple aim? We mentioned NICE earlier. NICE is an entity, National Institute for Health and Care Excellence out of the UK. A lot of their philosophies are starting to come over the pond. Someone mentioned earlier prevention. I think it was Ken. And so now we're seeing that, hey, by using this drug, by using this technology, what are we getting? And so they actually have an algorithm to look at the incremental value. And so they'll look at things like I talked about earlier, quality adjusted life years. So think about cancer, oncology drugs. By using this oncology drug, which is $100,000, $200,000, $300,000 a year, how much more life is my patient getting, right? What's their survival rate? Are they going to live 1, 2, 3, 4, 5, 5.2 months longer? What's their disability adjusted life year? If I pay for this modality, this therapy, are they going to be more productive, right? Is their health related quality of life going to improve enough that we should justify the payment of this drug? We've seen through NICE, we've seen in the UK and Netherlands, Spain. We've even seen the Johns Hopkins down in the DC, Maryland market. They brought over pharmacoeconomics specialists, and now they're having upfront conversations with patients. Ryan, here's the likelihood of your survival with your diagnosis. Ryan, here's the journey you, your family can expect. Here's what the capital cash outlay is going to be for you to go through this journey. Here's the adverse events you can come to expect. Here's the quality of life. Here's what's going to cost. Ryan, we've got a team where we can do shared decision-making where we, coupled with you and your family, can make a decision what you want to do. And so sometimes you're saying, hey, it doesn't make sense to pay $300,000 when you're going to expire in 1 to 2 to 3 months. So we're starting to see a paradigm shift in those conversations in healthcare in the US versus just, hey, we're going to pay whatever it costs as we think about that palliative care dynamic. So we're starting to see a little bit of that influence from that UK mindset through entities like NICE. Team, I'll pause there for questions, comments, thoughts. I touched on it earlier, real world data, real world evidence. That's becoming a paramount for our life science companies. Again, after phase 1, 2, and 3, when it comes to market, hey, now let's show us what the real world data is. And that's a good thing for pharma because it creates a lot of customer engagement opportunities and touch points to figure out, well, who on the payer or health system or integrated delivery network side should we engage with? Who controls that data? How are they performing today? What's the desired outcome? What are the issues driving down that outcome? What are the strategies? And so it creates a potential partnering opportunity where pharma can come in and they can have some congruency in aligning their strategies to get to those real world evidence outcome points that they want. So it's challenging. It takes a lot of time. It takes a lot of resources. But that's really where the market's moving is, hey, let's put your money where your mouth is. What kind of outcome can we expect in real world, not a clinical setting that's controlled? And hey, let's tie some payment to that real world. The last piece, team, and hey, whether you're in industrials, technology, whether you're in cement industry or healthcare, we like to look at the market through the following lens. Now, if you're like Keith that served our country as a captain in the Army before he got into pharma, thank you, Keith. Thank you, anyone else that served us. Really appreciate your service. So if you're from the military, you're very familiar with the PESTOL analysis. We like to take the Michael Porter Harvard Business School professor approach and look at the market through the PEST analysis. And so what we encourage you to do, if you're in healthcare, we like to look at Kaiser Family Foundation, KFF.org, Modern Healthcare, Atlantic Information Sources, PCMA Smart Brief, right? Whatever your sources are in healthcare or whatever industry you're in, we like to encourage people to take 25 minutes a day and read. And reading, we find, can make you more of that deep generalist, take you outside of your product, your portfolio, outside of your customer, your company lens, and think in a broader fashion. And when you're reading whatever that journal, periodical, news article is, we like to keep open a Word document in the form of a living PEST analysis. So we like to monitor what are those political influences, be it Medicare, Medicaid, Indian Health Services, Inflation Reduction Act. What are those political dynamics going on in the market? And what are the political dynamics unique to your healthcare ecosystem going on? Number 2, what are those economic drivers that are going on? 3, what are those social or socio-cultural dynamics going on? And 4, technological. Quick example, I'll be quiet, then I'll come over to Keith and Zoe. I was working with an account manager out in Nevada. That account manager happens to work in Parkinson's disease. One of his customers is United. And United said, hey, we'd like to do an outcomes-based contract, a value-based contract. Put your money where your mouth is, where your drug will deliver this outcome. Well, one of the technology drivers came through a company called Lifeguard. They could capture patient-reported outcome measures. And so what they did was they took that economic factor, coupled with some technology. They looked at some social drivers of health. These patients had off periods that were falling, and they were able to capture real-time data, come back to United in a value-based arrangement that was good for that Parkinson's patient, good for the health plan, and ultimately good for that pharma company, because with their real-world evidence, they were able to get favorable adoption of their product to the formulary. And it came from that account manager keeping a pulse on what's going on in the market. So Keith, Zoe, Beacon, team today, really appreciate your questions, your engagement, opportunity to interface with you. I'm sure if you have follow-on questions, Keith, Zoe can get you my info, And it's been a pleasure. Keith, Zoe, I'll turn it back to you.
Beacon is the premier executive networking organization serving the Mid-Atlantic region. To learn more, go to beaconforlife.org.